who is running for blood, make sure you have done a blood slide for malaria.
We people who work and live in Africa have to learn to design systems and produce products that will address challenges facing the patients that we serve.
When that season comes, I need a lot of blood. Maybe I would say I can transfuse more than 20 people in a day. But it's not that easy to give blood to children because we'll run out of blood from the lab, from the blood bank.
In a context where the majority of blood transfusions are for children, mainly as a result of anemia caused by malaria, it's important that the blood transfusion services supplies products that are able to address that major problem.
Blood can be delivered in different forms. The simplest is to keep it in the packs in which it's collected from donors, mostly adults.
So a whole blood adult pack has got an average volume of about 450 ml. But children only need a small volume of that.
The main alternative to whole blood is to make packed cells in the lab. These are used extensively in wealthy countries.
Packed cells is when we take whole blood, centrifuge in a refrigerated centrifuge, take out the plasma and add in a preservative solution. The product we make there are packed cells and they have a higher concentration.
In recent years, there's been a big push to build capacity to make packed cells in Africa. Many clinicians believe the high red blood cell concentration is more effective than whole blood. The third type of blood packs are called settled cells or red cell concentrates.
The red cell concentrates are made by just taking the whole blood pack, let the red cells and the white cells sediment to the bottom and decant the plasma.
The TRACT trial is the first big randomised controlled trial to look at how blood should be given to African children. 3,983 children were recruited in 4 sites in 2 countries, ensuring high-quality evidence. Through the trial, the researchers found that survival rates at 28 days and 6 months were the same for children given whole blood, packed cells, or settled cells.
Many people working in blood transfusion services have a strong belief that packed cells are better than whole blood. But I think we have to learn to listen to evidence. We are scientists. We should operate and do things according to the evidence. And the evidence is that there is no difference.
The trial also found no evidence to support the reasons normally cited as advantages of packed cells. There was no harm to children from using the larger fluid volume in whole blood, nor were there increased cases of transfusion reactions. And whole blood was found to be just as effective when stored for the same length of time as packed cells. But there is still a problem delivering whole blood to hospitals in adult packs.
In a setting like Malawi, when sources are already limited, if I get a 450 pint for a 10 kg baby who needs only 200 ml of blood, it means I have to throw away the 300.
The blood is thrown away because putting a full pack for a child in a busy emergency room risks giving an overdose.
If you're going to start a child on that 450 ml and sometimes you forget, it means you're going to give the 450 to a child who just needed a little. So you can see that in one way or the other, it's you either give too much, which is dangerous for the baby, or you have to throw away the extra, which could have helped, which could have been an asset for another child.
With children in desperate need of blood, while blood is being thrown away, clinicians often ask their hospital technicians to divide up adult packs, with nowhere sterile to do this.
Blood bank technicians have been splitting whole adult blood packs into small pediatric packs. When they make them on their own, there is a higher risk of bacterial infection in the transfused children.
The obvious answer is for blood transfusion services to make their own whole blood paediatric packs in a closed, sterile system to supply to hospitals, which is what they're now doing in Malawi.
All one does is to buy a multiple blood bag system. So you could buy a triple or quadruple blood bag system, where you have the primary bag that has got the anticoagulant preservative solution, in which we collect blood from the blood donor. Then it will be connected to other empty bags. Mix the primary bag so that there is consistency in the blood. Break the seal that connects the multiple bags to the primary bag, and then start transferring it into the smaller bags. And you have your whole blood packs. No additional equipment, just additional training in how to do it.
If you don't have multiple pack systems, alternatively you can connect ordinary single adult packs to several smaller packs in a safe way using a machine.
There is a small machine, costs about $20,000 or so, called the Terumo sterile connecting device. That machine will do the connection in a closed system with practically no risk of bacterial contamination.
It's a closed system.
Sometimes we take 2, sometimes 3, sometimes 4 empty packs, and the volumes would range from 80 to about 200 ml each.
Supplying paediatric whole blood packs to hospitals is much cheaper than supplying pack cells.
With making packed cells, we'll need more labor to be able to do the centrifuging, the refrigerated centrifuges, which are expensive machines, expensive to procure, expensive to maintain. So it is cheaper to supply whole blood pediatric packs.
In hospital emergency rooms, giving blood quickly may save a child's life. Having a pack with the correct volume immediately to hand saves time.
If we can have the packs that are going to be broken down in smaller units, that will mean we're going to maximize the resources we have, thereby helping the increased number of children by the day. So basically that's how I find it a very good initiative to have the smaller packs.
Making these pediatric whole blood packs is easy. I'm not trying to underrate ourselves here in Malawi, but if we can make them in Malawi, then everybody else can make them elsewhere.